I'm going to amplify a little bit of my background for the audience's benefit. Then I'm going to tell you a little bit about our company, and then I'll tell you about what we're going to cover for the next 50 minutes or so. In addition to my current work at Cancer Treatment Centers of America, and I'm celebrating my 5th year, I had served previously in 2 large academic medical centers at University of Kentucky in Lexington, and prior to that, the Cleveland Clinic. And prior to that, I was senior counsel for the American Hospital Association, and my first start was at a large law firm in Chicago. I tell you all that because I've always been on the provider side. I've always been an advocate when possible for change, and I'll talk about some of that in this presentation. And the confluence of my own personal background, understanding how law is made, helping to affect change, and more importantly, the clearly dynamic world we're in now with genomic medicine, it all comes together. I find it extremely exciting, and I'm actually very honored to be asked to speak here today. With respect to the company, Cancer Treatment Centers of America has been a company for roughly 30 years. It was founded by Richard Stevenson, who has other business interests, but he lost his mother to cancer in a situation that he thought wouldn't and shouldn't happen. She basically wasn't given enough information, options, and frankly, didn't feel as if she was the center of attention as she should be as the patient. So from that tragedy really became a vision that he pursued and has pursued successfully for 30 years. The essence of this company as a specialty cancer chain of hospitals is to focus on the patient, put their priorities first, and do it in a manner that integrates or incorporates many aspects of care. That's integrative medicine, complementary medicine, and of course, the rigor of scientific medicine, surgery, oncology, and the like. Now, I'm going to talk a little bit right now to level set this particular session. The term, or the title, Navigating Reimbursement for Oncology Patients and Care Teams, from my perspective, for my first 15 minutes or so, then I'll hand it off to Dr. Dixon and then on to Dr. Markman. My focus is really to try to talk to the audience to explain frustration points that patients experience. That's why it's navigating reimbursement for patients and care teams. Many of these points you probably already know. I just want to reinforce many of them based on my knowledge and experience, and hopefully that forewarns and forearms this audience for dealing with some of these thorny issues. I like the theme navigating because I've always been, ever since I moved to Chicago, a competitive sailor. And I want to tell you a story, partly because we're having the post-lunch relaxation, but it's a telling story and it's a good metaphor. I did my first Mackinac race, which is Chicago to Mackinac Island, back in my early 30s. And it was extremely exciting. It was on a 50-foot sloop, which was not the fastest boat, but it was in the middle of the pack type of boat. The Chicago Mac race is 333 miles. It's the oldest and longest freshwater race in the world. And it's now roughly 115 years old. It's very exciting. So I'm a member of the crew, and we're going up the lake, and someone's obviously navigating. I was just a grunt. I was working the jib. And we start talking about the other boats. So the cool thing is what's called the big sticks. So the big sticks are these 3- and 4-spreader super serious racing boats. And I asked the captain, I said, when are we going to see the big sticks? He said, oh, a little bit after dawn. Everyone gets a head start depending on size. So the little boats go first because it's all, it's all corrected time, and the big boats go faster. So it's dawn the next day, and the captain says, hey, John, take a look out back for the big sticks. So I look back there, and sure enough, it was just like out of a movie. I see 1, and then 2, and then 3 big sticks coming up the course. And then the wind starts to pick up. So we then pop our spinnaker, or pop the chute. So all the boats now, boom, have these colorful sails going. And I turn around and I look, and I see a really big spinnaker shoot out from what's called a Santa Cruz 70, a beautiful boat. And I said, hey, I just saw a big dark purple sail come out. And the skipper said, that's Larry's boat. I said, all right, cool. I said, who's Larry? He said, Larry Ellison. And I said, oh, yeah, Oracle. And he said, yeah. And I said, well, are those guys going to catch us? And the skipper, who was a former merchant mariner and a CEO of a big company in Chicago, he said, John, it's inevitable. So I sort of feel this conference and the idea of change, the idea of coverage, the idea of getting a confluence of all the parts together, of course, is inevitable. It's a question of speed. So sure enough, We're going up the course, and the big boys start coming up. So when they passed us, we're making anywhere between 8 and 9 knots average. So the big boys come by, and it's just like a freight train. They go by easily 5 to 6 knots faster, and you just see them take off. So the punchline is, if there is one, is that the transom of his boat, the name of his boat probably was or is Sayonara. So I guess that means goodbye, and I think we'll say goodbye to a lot of these old paradigms that we've been talking about for the first 4 hours today, and we'll start talking and focusing more on new paradigms. I hope you like that analogy. The other point about navigating is that you have to have waypoints. You have to find your course and go to one point after another, particularly for long distances. And those are called waypoints. I'm going to use that metaphor throughout my first 5 or 10 slides, because those are going to be links to other comments you'll hear from Dr. Dixon and Dr. Markman. And by the way, I also want to compliment Palmetto. I heard for the first time Dr. Apucha speak about reasonable, necessary. A lot of good stuff in his slides. He had to go pretty quickly. I'm going to amplify on that. I will cover fundamentals and the importance of terminology. Dr. Dixon will talk about what's happening with MolDX. And the good news is he has some very thorough slides. We're going to give him the lion's share of time to take us through those. And then Dr. Markman, who is the president and CEO of a CTCA company referred to as CTCA Medicine and Science, will take us through this exciting topic here. Maury and I worked closely together when we were both at the Cleveland Clinic, so it's really fun to sort of be back working with him in this capacity. Now I'm going to show you the first slide here that was developed through what we call our growth department. Some people call it marketing, but nonetheless, this is the results of some linguistics research. It's just one slide. If you'd like a little more depth, I'd be happy to talk to you afterwards. Let me give you some of the basics here. Of course, there was a pool of respondents that were asked to participate, and they were asked to look at these different terms or phrases and then start to think through their awareness, which means, have they ever even heard of the term? Second, if they said yes, what is their level of familiarity? And that is, do you think you understand, or are you confident that you do understand what the word means? And finally, the third level of analysis was understanding. So we were asking them, what does this term mean to you? Try to define it. And after that exercise, I'll give you the percentage results, after that exercise, they were given the so-called actual definitions, the best definitions we have as an industry. So here are some of the key findings. First of all, less than half of those surveyed understood the terms based on their ranking of actual understanding. But in terms of awareness, personalized medicine had 67% awareness and 57% familiarity, but an understanding of 37%. The next one, precision medicine, awareness was 45%, familiarity was 38%, and understanding was 12%. Genetic testing and genomic testing I'll rough them out together, were approximately 75% of awareness, approximately 60% of familiarity, and about 15% of understanding. So I just listed the top 4 terms. Other terms are a little more generic to our company, and we test these terms quite a bit. But that's kind of a telling statement about the importance of terminology. Now, I'm going to start talking about some of these waypoints. Frankly, there's more or less points of frustration for those in the field. First of all, we already know from the life science people and the innovators in the audience that early adopters go forward. And often with the reimbursement and payment structure, they're either blindsided or not adequately prepared. So they do some good work, they submit claims, perhaps it's an unlisted code or not otherwise covered as a first step, only to learn that their claims are being denied. That really is not a real positive sign for further activity, and that submarines quite a few endeavors and makes you less attractive to VC and others. So the next logical option in our system is to seek a coverage determination. There's 2 branches, you've heard some of the acronyms. There's LCDs, local coverage determination, and then there's the broader national coverage determination. It's a reflection of the size of the country, and that medical practices differ depending on what region you're in. But that's a process that's been around for quite some time. I think we all know that. What gets refined in terms of coverage options is the types of options that are available. So the parallel review process that's been adopted by the FDA and CMS is relatively young. It's a good intra-agency process. I won't bore you with a lot of the detail. The simple logic is a request is made, and the nature of that request has FDA jurisdiction, whether it's a device or drug, and then the process of review starts. Simultaneously, the people at CMS who have labored over how to work better and faster are working through a parallel review, and at the outcome of that work, you may get a positive determination. The one that's moved downstream faster in terms of, I think, progress is coverage with evidence development. I worked on one of these, that's where I cut my teeth, on partial lung reduction surgery when I was up at the Cleveland Clinic and trying to pursue coverage determinations of all stripes. And this one we were able to achieve. I emphasize this for distinction purposes. That was a surgical CED request. What happened was the patients were given treatment, and ultimately the data did not support a coverage determination. I say that to you because I learned after the fact, from a policy standpoint, that CMS can and will get a little gun shy with certain types of CEDs, in part because the genie is already out of the bottle. The fact that they've accepted a request for a CED, let it go forth, only to find that it doesn't really support further coverage, it puts knowledge out there, and sometimes it's hard to pull back knowledge either in the eyes of the patient or the practitioners. So there's a little bit of fuzziness about how willing the agencies are to pursue CED. My example was surgery. It may not be quite as fuzzy with the drug world. I'm not as familiar with that, and maybe Dr. Dixon can talk to that. I know he will talk to this exciting area, which is the coverage with data development. More of that to follow. Now, these are some more waypoints to think about as patients and as either consumers or providers. We want and need clear coverage information supported by fair and transparent coverage policies. You've already heard many stories at this conference about the need for transparency. It's just so real and so difficult for patients not to be able to comprehend why it is so hard to have my care covered. Next level is the providers and the payers. We talked about a viable framework at this conference and many others over the past decade. I think we're moving faster towards a viable framework that will address high-cost technologies, emerging technologies, and complementary integrative medicine. That's a large part, that last area is a large part of where we concentrate our care. So, moving into some terminology issues, how do we accommodate P-medicine within these traditional notions of medically necessary or reasonable and necessary items and services? And this is even more important as a concept because of what you've already heard and experienced, and Dr. Markman will speak to this, and that is the continuum of standard of care. Standard of care as a real concept keeps accelerating in terms of its application in the P-medicine space. Now, I'm going to spend the next 3 slides on, believe it or not, what really gets me excited, which is statutory construction, statutory language, and frankly, as an American and as somebody who pays a lot of taxes, as we all do, we need to help educate, and I mean that sincerely, we need to help educate, not lecture, educate people in Washington at the agencies about what we mean to say to them that's important about changing terminology. Let me amplify on that. Here is a 1965 50-year-old definition. Clinicians, I'm sure, have lived this and have seen their additional development request letters. They've seen their letters of non-coverage, and they've been frustrated. But I think the real important points are the choice of key words. Reasonable, necessary for the diagnosis or treatment of. I will tell you, I'll give you a little foreshadowing. I'm working with a group, which I'll talk about in about 1 minute, and we are doing a deep dive trying to understand legally what is the scope of the word diagnosis. Just hold that thought. The next major thought here is now a third of a century later, 1998, 33 years after the Medicare statute, the AMA, which of course moves carefully, sometimes glacially, but the AMA comes up with its policy statement of medical necessity. I'll just highlight the obvious. Prudent physician purpose of preventing, diagnosing, or treating. Think of that, preventing. We've heard a lot about predictive, prevention. I just think this particular clause is so ripe for adoption into a broader statutory scheme. We just need to define better in our own minds what's the difference between diagnosing or preventing or, in essence, predictive medicine. In any case, start with a prudent physician. The purpose of the service is to prevent, diagnose, or treat in accordance with generally accepted standards. This is what was so exciting to me last year when I came to this conference, to learn more jargon, KOLs, KPNs, MOUSC. There are so many neat phrases going on out there that we can latch onto that, again, as a community and interest. Generally accepted standards, clinically appropriate in terms of fill in all the nouns, all the verbs. And this is exactly what I heard here for the last 4 hours. A lot of these extremely bright physicians and life science people talking precisely about what is clinically appropriate, and then not primarily for the convenience of. This is stock Medicare language, which I'm sure you all know. Medicare cannot pay for private phones, and that's when they had landlines. So that's the AMA. So then we go forward to my last major point here, and this is just situational. I've been the vice chairman for the American Bar Association's Health Law Committee for the past 2 years. We just came off, we meaning what's called the Health Policy Task Force, which is a standing task force, probably more than a decade of experience. We just came off a project that led to proposed uniform law dealing with advanced directives and some other important issues of limitation of liability. So when I was on this leadership meeting about 6 months ago with a number of lawyers that I know or have met over the years by email, I just opened the door and said, look, I'm going to tell you a little bit about precision medicine. I'm a layman, but I will tell you a little bit about this. Second, once you hear me talk about it, there's 2 key points. First, people are dying. People literally are dying because we don't have the right method of thinking about getting to X, which is coverage and payment. Second point is we should go back as a fairly recognized body, the ABA, and let's take a look at the statutory definition of reasonable necessary, and let's talk to the knowledgeable medical community and scientists about concrete examples and suggestions. So right now, I have a meeting coming up in about 3 weeks with our task force. I told them, I'm going to be out here, and I hope these people throw a lot of good ideas. But we need to do this. We need to recognize the value of personalized medicine and its predictive and preventative possibilities. This is my email, and I really sincerely do ask for concrete examples. I walked away today with about 10, but you're the ones making it happen. I'm not a doctor. I play one on TV, that joke. But I really am sincerely interested in this. So that's my paraphrasing of the statutory definition issue. Now I'm going to move on to several more slides that go back to where I started, and these are the waypoints. These are the points where your boat's coming up and then the wind dies, or you have to tack away because you don't have right of way and that wastes time, etc. Or hopefully you don't hit rocks, which is a big danger as you finish the Mac race right near the Mackinac Bridge. Big rocks on the south side. Now, these are just norms, and I will tell you some of these takeaways here are reflective of work that was done by the American Health Lawyers Association in 2 iterations. They were called colloquia, and we got together, health lawyers, and we cogitated over the definition of medical necessity. And there's these beautiful papers that some of this excerpted from those papers where we as lawyers, with some help from clinicians, just chewed over why can't we come up with a better method of defining medical necessity? What is it that makes it difficult with that terminology to expand coverage as science explodes and advances, which it usually does before law? So examples. Many traditional coverage and payment methods rely on central tendencies of patient populations and disease. That's the way it works. I mean, I learned way back when about when Medicare changed its annual screening exam for prostate, you know the criteria, male, age, and you get 1 screening exam per year because that's what we know. That's our centralized tendencies of understanding that patient population and disease. And of course, thanks to the physicians in the audience, education of Medicare occurred, and now I guess we get 2 per year. Those examples go on and on. Second bullet point here, medical necessity and reasonable and necessary. Some payers use the term clinical coverage criteria that takes into consideration effectiveness and appropriateness of services. I like that because today I heard these terms being used in more concrete fashion, very concrete examples. This is the kind of work that we need to undertake, particularly from the bar, to help educate the people that make up the laws. Regardless of which term is used, many chronic conditions do not lend themselves to protocols or standardization. This is the sad reality. My father passed away 2 years ago of congestive heart failure. I understood, after working at the clinic, I understood a lot. But I could talk to his doctors, and my dad was a very bright metallurgical engineer, but he would refuse to believe that his chronic condition could not be handled in a proper manner. That was just denial. But I learned a lot about the difficulty of acute versus chronic disease. That's another black box that makes it very hard to figure out how do we as a country wrap our arms around reasonable and necessary in a chronic disease state. I'm getting down to the wrap up here. This is a nice, helpful slide that one of our physicians, Dr. Ed Steiner, helped me work up last year for another presentation. It's a very simple, logical progression here. I'm sorry. Genetic test performed. The test confirms a genetic mutation that may benefit from a targeted therapy. Actionable therapy includes the use of an FDA-approved but off-label drug. Reimbursement. All right, this is a little foreshadowing. Dr. Dixon will have a very nice treatment of this topic on slide 28 when he gets up here. It's a really, really good exercise that he's going through. So this is my wrap-up. Observations and discussion points. A decade ago or more, payers, physicians, and government regulators simply weren't ready for P-medicine. You heard me talk at the outset about what is the definition of P-medicine to begin with. Second, it's too difficult to grasp the value proposition. I don't have to repeat what you heard many times today from the medical directors, from the payers. It's an important, real situation we have now as a country, putting value back into actual methods of reimbursement, coverage, and the like. Another very basic point that I believe people are trying to tackle, which is the AMA CPT coding system. It truly is activity-based. It's not really ready for prime time for value-based services, but we need to get there. I think you probably are familiar with some of the other related work going on with McKesson and others, trying to use a nomenclature, a coding nomenclature, to absorb this explosion in activities, line item by line item, that's reflective of personalized medicine. I'm not sure that gets us to the value proposition, but that's a real theme that we've got to focus on. The last point is what we've heard too. Clinical utility often can be demonstrated via clinical trials, but uncertainty remains about regulations, coverage, and payment. These are some references. I was going to spruce this up a little bit, but didn't have time, frankly, because there's so much coming out. I mean, the literature is so quick. These two, I think, were very helpful, at least for me, to get up to speed as well as to tee up for this particular meeting. And my last comment, years ago, I had a little boat, and I named it Sailbad the Sinner. Don't tell anyone that. All right, thank you. I'm going to turn it over now to Dr. Dixon. Thank you.